Welcome to the 21st ACNN Webinar. Today we have Prof. Aditya Gupta. He's the Director, Neurosurgery and CNS Radiosurgery, Artemis Agrim Institute of Neurosciences, Artemis Hospital, Delhi. And he will join us at 7:30 afterwards. So our next speaker will be Mrs. Sindhu Gautam. She's the nursing officer, Beer Hospital, Kathmandu, and she will talk on the role of an OR nurse in functional neurosurgery. Miss Christin from Indonesia will talk about neurosurgical nursing in Siloam Hospital, Indonesia. And our session chair will be Dr. Navrata. She's a consultant neurosurgeon, National Neurosurgical Referral Center, National Academy of Medical Sciences, Beer Hospital, Kathmandu, Nepal. And the Miss Tia Marina will be the session chair for the nursing. She's the Nurse Associate Neurosurgery Clinic, National Brain Center, Hospital, Jakarta, Indonesia. And our commentator today is Prof. Kim Kyusu. He's an Assistant Professor, Functional Neurosurgery Department of Neurosurgery, Tokyo Women's Medical University, Tokyo, Japan. So without further ado, I would like to call upon Prof. Kato to give a few words before we start with the nursing session.
Yes, thank you very much for organizing such a wonderful webinar. I think so. Dr. Kim, I know him since he is very young. So now he's a great teacher. And today's the all topics is very, very interesting for us. So please start. Thank you very much.
Just give me 1 minute, yeah. On behalf of the ACNN, Prof. Kato, congratulations on this wonderful achievement, winner of the WFNS Slovenia Award 2025. Congratulations again, Prof.
Thanks so much. That is not only for me, but also that is due to your effort, the sport. Thank you so much.
Okay. Miss Tia Marina, can you please start the first speaker?
Okay. Thanks for the opportunity, Mrs. Yi. Good evening, everyone. The distinguished guys, colleagues, and friends. Welcome to today's nursing session on the role of the operating room nurse in functional neurosurgery. My name is Tia Marina, and it is my pleasure to serve as the session chair for this program. Our first speaker is Mrs. Sindhu, an operating room nurse from Nepal. She will be presenting on the role of the nurse, the role of the OR nurse in functional neurosurgery. Mrs. Sindhu Gautam is a nursing professional from Nepal with extensive experience in operating theater management and long-standing service at Beer Hospital, where she currently works as a nursing officer. She has complete advanced international trainings in Japan, China, and India, and actively participate in major neurosurgical and medical conferences across Asia. Please join me in welcoming Mrs. Sindhu. Mrs. Sindhu, the floor is yours.
Thank you so much. Thank you, Ms. Tia, and thank you so much. Namaste, everyone. First of all, I would like to thank the organizing committee, Professor Kato, Ma'am, Metro Ma'am E. I'm very grateful for the ACNS. Today, I'm going to talk on, okay, I'll be sharing my screen. Today, I'm going to talk on role of OT nurse in functional neurosurgery. Today, I'll be sharing our experience, our responsibility, and our challenges that we are in growing new in a functional neurosurgery. Overview. This session will include a brief introduction of functional neurosurgery and major responsibility of the OT nurses, because we face many challenges. So initial phase challenges, our experience and learning, and finally the conclusion. Functional neurosurgery is an advanced subspecialty, as all we know, focused on the improving neurological function. It use very precise technique to modulate the specific brain circuit. Procedure include stereotaxy biopsy, DVS, epilepsy surgery, lesioning, and other pain procedure, and the movement disorders. We are in initial phase. Our current status at our center, we are starting the first. We are currently starting the functional neurosurgery. We are currently developing the protocols, understanding the workflow, and learning the new equipment. As a OT nursing team, we are adopting step by step by building the confidence with each other. What procedure we did? Mainly, we did stereotaxic biopsy. We started stereotaxy biopsy about in 2017, I guess. Then we are starting DVS only after 2 years ago. 2 years ago, we did DVS, VNS, epilepsy surgery, lesionectomy, pain, and movement disorder. This procedure require accuracy, coordination with the team, and careful handling of the sensitive equipment. So, preoperative role. Preoperatively, the OT nurse prepared the operating theater based on the functional neurosurgery standard. It includes preparation of the stereotactic frame, navigation system. We have to ensure the sterility of the all equipment. We coordinate closely with the neurosurgeon, anesthesiologist, neurologist, and the technician. For the awake surgery, we also provide the psychological support to the patient and keep them calm with cooperation. Intraoperatively, we support all the technical aspects also, such as MES setup, impedance check, connecting the stimulators, and assisting during the mapping also. Even though the new technology for us, but we handle it with very careful and with our strong desire. We maintain sterility strictly because we are OT nurse, and we assist in positioning, especially for the awake surgery, and anticipate the surgeon's next need, because the role of OT nurse is very important there. Our role to ensure the smooth surgical flow throughout the procedure. Challenges in initial phase. Being in beginning stage, the biggest challenges we face are learning the new technology, handling the delicate as well as expensive devices, communicating effectively during the awake surgery, coordinating among the multiple team simultaneously. And also we have to formulate the idea for the patient draping, as there is not available a proper drape in our country. I call many companies, people, do you have this DVS drape? Do you have drape for the Siam? But there is no availability of proper drape. So we use large microscope drape for draping and cut the size accordingly. Then we become success in that. How we overcome these challenges through our continuous learning, hands-on practice, team discussion, and most importantly, we build our confidence. We are not afraid to ask questions and clarify our doubt and learn together. Functional neurosurgery is a high I guess functional neurosurgery is a highly team dependent. The OT nurse is a central link to connecting the surgeon, anesthesia, and the technical team. Successful outcomes are entirely depend on teamwork and the communication. So far, each case has added to our skill and confidence. We are gradually mastering the equipment handling, improving the coordination, and building a strong functional neurosurgery OT nursing team. And now I want to, before conclude, I want to share one thing with you. I was fortunate to have opportunity to scrub with Professor Kato as well as in vascular surgery. Also, I scrubbed with Professor Aditya in DVS surgery at its first center. That was my first scrub in DVS. We are also deeply grateful to Professor Mark from the US for his invaluable support in helping us in initial stage of DVS, VNS, and listening and other functional neurosurgical procedure. So we remain sincerely thankful to both of them for guidance and continuous encouragement. To conclude, OT nurse play a vital and irrepressible role in functional neurosurgery. See, even we are in initial phase, our dedication and our teamwork has made our progress very strong. This is a photo after the functional neurosurgery workshop. Here is a Professor Mark from the US. And we get many chance from him. Thank you so much. Thank you for listening.
My turn, G.
Okay. Thank you, Mrs. Sindhu. Our next speaker is Miss Christin from Siloam Hospital. She will sharing her topic on neurosurgical nursing in Siloam Hospital. Mrs. Christin Rouli Juni Sihite is a pain nurse coordinator at Siloam Hospital, Lipo Village, with strong expertise in post-operative management, IV therapy, patient safety, and neurosurgical nursing. She is actively involved in national and international professional organizations, including serving as the honorary vice chair of the Asian Congress of Neurosurgical Nurse, or ACNN. She has presented at multiple international conferences and contributed to published research focused on the patient safety and neurosurgical nursing. Let us welcome Miss Christin. Please proceed with your presentation.
Yes, thank you. Good evening for Professor Kato and Professor and distinguished. And please, I want to share my screen. Okay. Is it clear from my screen? Not yet.
Yes,
okay.
We can see.
Okay. Thank you. Thank you, Prof. Thank you for opportunity. My name is Christin. I am working in Siloam Hospital, Lipo Village in Indonesia. And excellent of my hospital is neurosurgery. Yes, this is the profile of my Siloam Hospital, established in 1996 under PT Siloam Hospital International, employs more than 6 nurses, and neurosurgery a service of excellence at Siloam Hospital, the first Indonesian hospital group accredited by Joint Commission International committed to excellence, safety, and compassionate care. Hospital service performance. This is my background. We have 41 hospital nationwide, and to now Siloam Hospital Lippo-Village is the white of hospital in Indonesia. Yes, how about the background? This is I want to share, professor and nurse and doctor, all of you. I want to share about the background neurosurgery and neurosurgical care in Indonesia. The background slide highlight why neurosurgical services are essential in Indonesia. Neurosurgical diseases such as stroke, epilepsy, and brain tumor remain major public health challenges, with stroke being the leading cause of the death and disability. As a population continues to age, the demand for advanced neurosurgical care is rapidly increasing. Siloam Hospital has perform more than 20,000 complex neurosurgical procedure, positioning as a national leader in neuroscience excellence. And now, Siloam Hospital as a hospital ready for stroke for 2025. Siloam Hospital officially launched the Siloam Hospital officially launched the Brain Labs robotic suite for advanced brain surgery, and this technology represents a major leap forward in precision, navigation, and surgical safety. This is the neurosurgery team, and lead is Professor Eka. Pioneer Professor Eka always make a nurse as a team, like always give teaching and bedside teaching for the patient and new cases or difficult cases for nurses. Professor Eka, pioneer of Southeast Asia first breast stem surgery, and a visionary neurosurgeon who inspired Siloam nurses to deliver extraordinary care, combining skill, compassion, and dedication in every act of healing. Yeah, for the technology and new innovation make nursing challenges for staffing and specialization, with neurosurgery being a high complexity service. The adequate specialized neurosurgery nurses is key. Technology change, introduction of robotic demand, new competencies for nurses, and safety and quality. High-risk neurosurgical patients require rigorous monitoring, risk management, example, falls, neurological deterioration, pain, and infection. Use this as a baseline for nursing service. Contribution, example, neurosurgery per year, what nursing staffing model is needed, and what quality indicator we make benchmark in national in Siloam Hospital group, infection rate, length of stay, fall rate, and readmission for special for patient after neurosurgery. Yeah, I'm so interesting with this image because neurosurgical patient cannot wait. The critical role of nurses, intracranial pressure, the brain, similar the aircraft cockpit, controlling all body system. Continuing for the assessment, we can monitoring ICP of vital indicator, show internal pressure. If elevated, visit dangers. For nursing, I always influence my nursing because monitoring critical indicator and acting rapidly, fake action, preventing permanent psychological crash. Preventing the goals is preventing irreversible brain damage. Yeah, Siloam is recognized regional for high volume neurosurgical practice and 24/7 neurosurgical emergency readiness, state-of-the-art neuro ICU, experiences neurosurgeon and specialized nurses, Evidence-based protocol aligned with global standard, we combine precision medicine with compassionate care. Yeah, we have a patient journey. Patient journey in Siloam Hospital, Report Village. It begins the pre-hospital triage, where the first decision determines how quickly the patient receives definitive care in the emergency. And after pre-hospital and triage, patient go to emergency department, and the next diagnostic space, preoperative, intraoperative support, neurosurgical ICU if a patient go to ICU, ward recovery, rehabilitation, and family education. And the last journal is safe discharge and long-term follow-up. We have one after patient discharge, 24 after patient discharge, we can follow up the patient. We ask about the pain and about the insertion infusion and about the when the patient must control to the hospital. Yeah, maybe this is the crucial for patient after surgery, like monitoring critical for nurses. When the patient began hypoperfusion and sign and symptom for the herniation, this is image which I always share for my nurses, because we must know about the sign and symptom, how monitoring and reassessment to monitoring if the patient have increased intracranial pressure. Yeah, I want to share about the pre-hospital and triage. Neurosurgical nurses assist in rapid triage based on neurosurgery. For the stage 1, pre-hospital and triage, we can assessment the patient is trauma head injury or no, stroke-like symptom, mass effect sign like vomiting, headache, and weakness, and seizure. Neurosurgical nurses assist in rapid triage based on neuroseverity, prioritizing high-risk patient, communicating early alert to neurosurgery, preparing ED or emergency department for immediate intervention, and the goal outcome patient faster door to neurosurgery activation. Yeah, we have a team neurosurgery team is always standby 44/7 in every day. And for the stage 1, nurses in emergency department care, assessment rapid neuro assess like GCS, pupil motor deficit, stabilis of the airway and circulation, and the next preparation for CT or MRI, and immediately manage of seizure, agitation, or neurologic decline, and ensuring cervical spine protection for trauma patient. Neurosurgical nurses, this goal in the stage 1 in emergency department care is accurate and speedy determine outcome. Yeah, for the next stage 3, diagnosis phase. This is nurses coordinate. Nurses coordinate is very crucial in this stage, because we must collaborate with and ensuring the assessment, communication, and intervention happen immediately and accurately. Yeah, after patient go to the stage 3, if the patient go to the OT operating theater, pre-operation optimization goal is reduce intraoperative complication through the precise preparation. Neurosurgical nurses prepare patient thoroughly by recording neurosurgical baseline for the all about the assessment, managing AV access, line and drips, preparing surgical site. We have site marking and supporting family and communication and consent, verifying imaging, labs, implant, and blood unit. In Siloam Hospital, we have EMR, electronic medical record, in of ward, in operating theater, AED, and ICU and general ward. In operative neurosurgical support, Siloam Hospital goal is deliver precision-driven support during surgery. Special OR nurses ensure the handling of advanced neurosurgical equipment. This is always maintaining sterility for long surgery, for the fluid, blood product, and implant, close coordination with anesthesia for neurostability, and rapid response to bleeding or brain swelling. And in the operating theater, we have anesthesiology, and anesthesiology is responsibility until 24-hour patient after surgery. And how about the monitoring in ICU? In ICU, we have a doctor with the closed system in intensive area in Siloam Hospital. So no many instruction, because my concept in ICU is closed system. The lead is in intensivist. Okay, how about the management if the patient in ICU? We have 12 care nursing management, neurological monitoring. We can also check GCS, pupil size, reactivity, neurosign regularly. Is it to detect early sign of deterioration and increase ICP? How about the pain management? We have improvement GPOT scale in my hospital for patient after surgery, because sensitivity is very good, until 86% for patient pain, administer multimodal analgesia. In ICU, we also usually give opioid analgesia like morphine and midazolam for patient after neurosurgery. In rationale to reduce pain, induce stress that can increase ICP. How about the hemodynamic monitoring? Hemodynamic monitoring, nurses must assessment and reassessment about the blood pressure, CPP, and maintain mean arterial pressure if 65 mmHg to ensure adequate cerebral perfusion and prevent secondary injury. And the next, temperature regulation to manage fever with the medication or cooling, and monitor temporarily closely 1 hour to prevent increased brain metabolism and future complication. And respiratory management, support ventilation, monitoring SpO2 and ATCO2 suction as needed. After every morning, we check blood gas for every patient to maintain oxygenation and prevent of hypoxia-related damage. Yes, the next key nursing management is seizure prevention. Administer anticonvulsion from doctor, observe for the seizure sign to avoid IC spike and additional neurologic damage. And in ICU, we early ROM exercise, elevate limb to improve circulation and prevent venous thromboembolism. Skin integrity, turn patient every 2 hours, inspect pressure point, use air mattress, and immediately patient after surgery, we can turn patient to prevent pressure ulcer and skin breakdown. How about the infection control? Maintain hand hygiene. We have audit monitoring every performance like doctor, nurse, physiotherapy, and dietitian. We have audit every month for hand hygiene after patient, after from the patient or before the patient 5 moments. Monitor wound and drain to reduce ICU acquired if infection and ensure recovery. Communication and handover, use SBAR, situation, background, assessment, and recommendation every shift. And family education. Every morning, Prof. Eka and team always give education and update about the condition patient, if the patient after surgery or not, because family education or family or patient satisfaction is number one in Siloam Hospital, and the justification for to reduce anxiety and improve compliance with the care plans. Yes, this is a multimodal pain strategy and nursing role in neurosurgical care. Pain management strategy, importance of effective pain control in neurosurgical patients. Multimodal pain management approach opioid and non-opioid regional technique, balance sedation every shift or every 8 hours. We can monitoring about the needed sedation for the patient. And nursing improve include strength and mobility reinforcement, cognitive stimulation cue, safety reinforcements for neurosurgical deficit, daily collaboration with speech therapy, and monitoring fatigue and neuro recovery tolerance. Rehabilitation begin early, not after discharge. Yes, I believe because with the caring and with the implementing evidence-based nursing practice in intracranial surgery significantly improve both nursing performance and patient outcome, including and increase in the patient satisfaction. This is example journal, because enhancing nursing practice through patient outcome measure a framework for optimizing care in intracranial surgery. Every Friday, we have a case study in my hospital for the refreshing about the knowledge for all nurses. This is my team in ICU, and this is my ICU. We have 3 cubicle, and every cubicle we have 4 beds. Yes, the strength of the neurosurgical nursing in Siloam, highly trained nurses with the structural competency pathway, standardized neuro assessment framework we have, advanced monitoring technology, integrated communication system, culture of safety and accountability, strong surgeon and nurse collaboration, patient-centered care at every stage. Siloam combines skills, technology, and humanity. Yes, this is my patient after neurosurgery in pineal tumor, and after before he is discharged from hospital, he is come to ICU, and we very glad because the patient is very good. And summary, Siloam neurosurgical nursing is built on strong competencies, standardized neuro assessment practice, and the use of advanced monitoring technology. Our communication system are well integrated. Our safety culture is strong, and collaboration between surgeon and nurses is a must. Above all, remain patient-centered care every step. In short, Siloam combines skill, technology, and humanity to deliver exceptional neurosurgical care. Okay, thank you from me, and good evening. Thank you, Prof.
Good evening, Mrs. Christine. Thank you, Mrs. Sindhu, Miss Christine, for your inspiring and excellent presentation. The Q&A session will be held at the end. So I now return the session to Mrs. Yi.
Welcome, Prof. Aditya and Dr. Navrata. Now the session, Dr. Navrata will chair Prof. Aditya's session. Dr. Navrata, are you there? She's in.
Yes, ma'am. Namaste, everyone. Yes, ma'am. Namaste. Yes, sir. So, shall we start?
Yeah, please. Can you please chair the session for Prof. Aditya?
Yeah. Very good evening, everyone. So this is my absolute honor to be chairing this session today, and it is even more special and emotional moment for me because you have all given me the honor of introducing someone who has shaped my own neurosurgical journey, and he is Dr. Aditya Gupta. So for me, this introduction carries a special emotion, as I have already expressed. So I had the privilege of working under him for 3 months in Artemis Hospital, Gurgaon, a period that deeply influenced me. And he is my guru, my mentor, and I look up to him, and his guidance, discipline, and generosity have always left a lasting impact on me. And ladies and gentlemen, I would again like to say that it is really my honor to welcome Dr. Aditya Gupta. And for me, he needs no introduction. And for people around the world, I would like to say he is the director of neurosurgery and CNS radiosurgery at Artemis Agrim Institute of Neurosciences, Artemis Hospital, Gurgaon, Delhi, and he is a former associate professor at AIMS and additional director at Medanta. He is a renowned expert in brain tumor, microsurgery, radiosurgery, epilepsy, and DBS surgery, aneurysm, and EVM. And I would like to say he's an expert in all the arena of neurosurgery. He has got distinguished career is marked by numerous honors like Best Student, Sir Dorbazi Tata Award, Best Research Paper Award, Boycott Fellowship awarded by the President of India, and Chief of Army Staff Award. And with his numerous, more than 45 scientific publications and 6 book chapters, I think the leadership roles in his Neurological Society of India, and then Indian Society of Stereotactic and Functional Neurosurgery, the Skull-Based Society of India, and ACNS. His contributions have significantly stepped our field and shaped young neurosurgeons like us. So apart from his brilliance in neurosurgery, he is also a remarkable poet, someone whose words reflect the same depth, precision, and humanity that define his work in the operating room. So, ladies and gentlemen, I would again like to say it's really been an honor to welcome my guru, Dr. Aditya Gupta, for the lecture.
Thank you, Dr. Namrata. It's a pleasure to see you, and thank you very much, Matron Cheng and the ACNN committee. And Dr. Namrata, that was a very, very excessive introduction, I must say. It's actually my pleasure to be here with all of you. I don't know if my slides are showing up.
Yes, sir. It's showing up.
Is my title slide showing?
Yes, sir. Yes, sir.
Okay, perfect. So I'll proceed with a 15 or 20-minute introduction to functional neurosurgery. It was nice to see Sindhu as well, giving her talk. And I think she has explained many things on the nursing side, which are very, very important. I'll just take you through an overview of functional neurosurgery. And basically, it is to me, it is a very, very special branch of neurosurgery in which, as the name tells you, that we are trying to impact some neurological disorders by altering the brain networks and brain functions. So this is in contrast to the usual work of a neurosurgeon, in which we want to set right structural things in the brain and the spine. Now, the full name for this subspecialty, of course, is stereotactic and functional neurosurgery. And a lot of it has to do with the technique of stereotaxy, which I will try to explain in maybe just a few slides. So what I was trying to say is that we are trying to treat in functional neurosurgery, we are trying to treat these very, very difficult disorders which you see on the slide: movement disorders, epilepsy, pain, psychiatric disorders. I think these are the main indications for functional neurosurgery. And these come to a functional neurosurgeon, obviously, when the medical management and the other methods have been exhausted. So it's only when these disorders are refractory or they're resistant to the medical management that they land up with a functional neurosurgery team. And what we need to understand is that these are all circuits which are located in very deep parts of the brain. So how do you reach these very deep parts of the brain? So stereotactic neurosurgery has a very, very rich history, and it began with a lot of animal work. Then Hosty and Clark actually, they hit upon the brilliant idea that if you can fix the head in a frame, then basically you can correlate any structural area in the brain with the geometric coordinates. So if you are familiar with coordinate geometry from your high school, this is basically a Cartesian three-dimensional coordinate system which is related to the third ventricle. And as I said, with a lot of animal work, then we had human frames, and this is one of the most popular stereotactic frames, which I used when I began my neurosurgery training in 1995. This is the Lexel, one of the older versions of the Lexel frame. And of course, now we use a very, very current and modern version of the same frame. Now, what are the techniques that we use to approach these deep areas in the brain? And as I said, a lot of these interventions are in areas in and around the third ventricle, mostly the thalamus and the basal ganglia. So the tools available to us as neurosurgeons are, first of all, you can remove a part of the brain which is firing abnormally and thereby interrupt the network. So the classic example being epilepsy surgery. Second, what you could do is to disconnect the circuit so that the firing stops. That is something which we do in epilepsy and also in pain. So there is a procedure called dresotomy in which the dorsal root entry zone is sectioned and thereby creating a disconnection in the pain circuit. Now, the third technique that we use is a very old technique. It began in the 1950s and 60s. It is called as a lesioning. And typical examples of lesioning is pallidotomy and thalamotomy. And I think Sister Sindhu talked a little bit about that. And what we can also do is apply it to stimulation. So deep brain stimulation is the current technique which is very, very popular for dealing with a variety of neurological disorders. And also, radiosurgery is a very special application in which radiation can be targeted very, very precisely using the coordinates to practically any area of the brain that we want to target. Now, let's begin with movement disorders. So movement disorders, as you know, are disorders, for example, like Parkinson's disease, essential tremor, dystonia, and there is a host of many, many other movement disorders for which the circuit has been very nicely worked out. Now, the options available to us, which I already mentioned to you, is anatomic lesioning, in which we put in a lesioning electrode and we heat the tip of the electrode typically to around 70 degrees for anywhere between 40 to 60 seconds. And that creates a very precise lesion in that part of the brain. With deep brain stimulation, we can insert an electrode into that part of the brain. And basically, a high frequency stimulation is actually acting like a physiologic lesion without destroying any part of the brain. There are certain other procedures in which we can do a partial neurotomy or section a part of the nerve to give relief to certain focal dystonias. And intrathecal baclofen pump is another method which we can use to give some benefit to, for example, patients with a pediatric dystonia. So this is a MRI picture of an example of a lesion in the globus pallidus. So if you can see my cursor, this is the lesion located in the posterior third of the globus pallidus in a patient who had a hemidystonia. From lesioning, we have gradually moved to stimulation, which I mentioned is called as deep brain stimulation. The reasons are that DBS surgery is reversible. You are not creating a lesion in any part of the brain. But really, the major reason why deep brain stimulation has taken over the lesioning is because it can be safely done bilaterally. In lesioning, typically you can do lesioning on one side. You cannot do at the same session a lesioning bilaterally in the brain that will have some long-term and permanent complications. For example, if you do lesioning of the globus pallidus, which is called as a pallidotomy bilaterally, then you could have a patient with a problem in language, with a problem in speaking, and therefore these lesions cannot be done bilaterally. Now, neuromodulation is the current name for the techniques whereby we can alter the neural function using electrical, electromagnetic, or pharmaceutical agent directly into the target area. So one example which I gave you is intrathecal baclofen pump. Another example which I gave you is deep brain stimulation. And transcranial magnetic stimulation is a non-invasive technique using which we can again change the modulation of the nerve activity in a particular area of the CNS. So one interesting thing which is developing is when we began using DBS, and my first DBS was some 25 years ago, the only option was that you had a wire which went into the brain and that was connected to a pacemaker. Now, what we are seeing today, and which is something which is available, is that the device gives you feedback through which the programming can be done by the neurologist. And based on the feedback from the electrodes, the programming and the stimulation can be tailored very nicely. Now, DBS has a very interesting history. In fact, it was a chance discovery by Professor Benabid, who is a famous neurosurgeon from France. And while doing a lesioning, a thalamotomy, he decided to do a high frequency stimulation using that same needle. And he found that high frequency stimulation actually acted like a lesion, but you could modulate, you could play around with it without creating a lesion in the brain. So this is what ushered in the era of deep brain stimulation surgery, which, as you know, is a very, very well-known and FDA-approved indication for movement disorder treatment for both Parkinson's disease, essential tremor, and for dystonia. So Parkinson's disease, dystonia, and tremor, these are the three important indications for deep brain stimulation or lesioning. And the targets actually depend on the disease that you're trying to treat. So for example, if you are treating Parkinson's disease, the favored target is the subthalamic nucleus, which you can see here on the photograph on the right side. That is the subthalamic nucleus. Whereas if you are treating dystonia, then the favored target would be the globus pallidus. The globus pallidus, now you can easily make out in an MRI image that this is the globus pallidus. And in fact, what we target is the internal part of the globus pallidus, which is called as the GPI. If you're treating a patient with tremor, the target is one of the nuclei of the thalamus. So somewhere here would be the VOA, VOP if you had a patient with the writer's cramp, or the ventral intermediolateral nucleus of the thalamus if you are treating essential tremor. In a DBS procedure, essentially what we plan to do is to put an electrode into the area of interest. So here is a patient with Parkinson's disease. And in the yellow color, what you see is the subthalamic nucleus into which the electrode has been inserted. To give you an idea of how it looks like intraoperatively, as the electrode passes through the brain, very, very typical activity of the subthalamic nucleus can be picked up by using what is called as the microelectrode recording system. So we actually put 5 leads into the brain when we are doing a DBS for a Parkinson's disease. And in the tract that we get a good recording, in that tract, we put the final electrode. So this is a patient undergoing deep brain stimulation, and my colleague, you can see, is evaluating for the speed of the movement. So you can appreciate that the speed of the movement is not very good. And you can also see that the patient is there with the stereotactic frame and the stimulating electrode is inserted inside the brain. And this is an awake operation which is happening. And after switching on the stimulation, just look at how fast the movements have become. And what my colleague is also assessing is the rigidity in the muscle tone, which can easily be picked up. Now, this is a patient on the day of DBS surgery, just before the surgery, when we have applied the stereotactic frame. So this is the current version of the Lexel frame that we use for DBS surgery. And this is a patient who we call as a young onset Parkinson's disease. And you can see the slow shuffling gait. She is not able to walk. And this is on the day of the DBS surgery. And this is the same patient the next day after DBS surgery, in which you can see the surgery has been done. And this patient can actually walk around by herself. And she has very, very good improvement, which is evident on the very next day after surgery. Now, this is dystonia. This is my earliest case of dystonia, I think in 2005, 20 years ago. And this is a patient who had primary generalized dystonia, which was D-vitamin gene positive. And this patient had a very, very bad quality of life before the operation. And this is the same patient 1 month after DBS surgery, in which you can see that the patient is very, very much better compared to how he was before the operation. So movement disorders are diseases in which we can really give a lot of improvement to these patients who have a very poor quality of life. We have been very happy to have a significant experience with DBS across many, many different indications. Some of them I will cover. And the main indications you can see is movement disorder, which is Parkinson's disease and dystonia. And we've also been happy to do 15 DBS for epilepsy, and in fact, 1 DBS for obsessive compulsive disease, which is a psychiatric disorder. Now, neuromodulation is something which is actually the indications are exploding even beyond the neurological diseases. This picture shows you that in the next 20 years, neuromodulation is really going to become very, very big. And indications like headache, indications like cardiac pain, indications like incontinence, even gastric indications are going to come. Now, the second part of my talk is epilepsy surgery. And epilepsy surgery is also a very, very important and I would say very gratifying part of the work, because you are dealing with patients who are not seizure-free despite taking 3 or even 4 medicines. So first we do a lot of evaluation of these patients and we come to a conclusion as to which part of the brain is responsible. And then we can subject this patient to one of the different kinds of epilepsy surgery, which I mentioned briefly in the beginning. So if you can identify a focus which can be removed safely, then you go for the focus-directed epilepsy surgery. If you cannot remove or the focus is widespread on one side, then you can disconnect. And the typical example is a corpus callosotomy or a functional hemispherotomy. Lesioning can also be done for epilepsy, and neuromodulation, which I mentioned to you, is that we can use vagus nerve stimulation or we can use deep brain stimulation for very, very specific patients who have multiple seizure foci on both parts of the brain, so that you are not able to remove, you're not able to disconnect. This is a typical example of what is called as a mesial temporal sclerosis. And you can see here that the left side of the hippocampus is shrunken compared to the right side. Right side has a very, very nice appearance with these undulations, and the left side is shrunken and these undulations are lost. So this kind of a patient, what we do is and this patient was actually having complex partial seizures, which are very, very easy to miss. And if you see the seizure, he is basically having this dystonic posturing of the upper limb and lip smacking. These kind of complex partial seizures can be easily missed. And this patient was having 3 to 4 such episodes every month, and the school performance was going down. So when we worked him up, the MRI and the video EEG and the PET scan all showed that this hippocampus was the one responsible. And what we did is an anteromedial temporal lobectomy, in which we mobilize the temporal lobe. Then what we do is we go into the temporal horn of the lateral ventricle. And this is actually the hippocampus beneath my suction. And this has to be then separated from the arachnoid that is lying over the brainstem. And this is the tail of the hippocampus, which can then be, it can be cut right here, and the entire thing can be delivered as a single specimen. So epilepsy surgery is something which is very, very gratifying, and you can make a patient who is having multiple seizures every day. Such a patient with the correct epilepsy surgery can become free from seizures. But what we need to understand is that these patients are very afraid of surgery. And therefore, I think all of us, doctors and nurses, and the general public needs to be aware that epilepsy surgery can have a very, very big impact on the quality of life. But they need to be referred to a specialized center which is doing these kind of operations. So the last 5 minutes about radiosurgery, which is a very special application of the stereotactic technique, in which we precisely deliver a very high amount of radiation, but very precisely to a particular area in the brain or even in the spine. And that is why it is different from radiotherapy, because in radiotherapy, we are delivering multiple sessions to a very large volume. Now, radiosurgery is something which is very, very popular, and it is something that the brain tumor patients, especially, they come asking for it. Any patient with a brain tumor, they say that they want to have a cyber knife or a gamma knife surgery. So the good thing is that there are a variety of tumors and lesions which are very, very effectively treated with radiosurgery. And the best part is that radiosurgery is practically a zero risk and a zero pain procedure. And in fact, using the gamma knife or the cyber knife, in 40 minutes, you could actually treat a patient and they could go home the same day. This is the earliest description of radiosurgery by Professor Lexell, who, as we all know, was a very well-known pioneering neurosurgeon from Sweden. And in his lifetime, I think he contributed a very, very large amount to the progress in the field of stereotactic and functional neurosurgery. So in this, he actually mounted a X-ray tube on top of an early version of the Lexel frame. And from that time, we of course have different platforms which have come in. The basic technique is that you are cross-firing multiple beams of radiation so that at one particular point where the tumor or the target is located, you have a very high dose of radiation. And at other points, the radiation dose can rapidly fall away. So you can practically achieve the same result if you have a very special kind of a linear accelerator, or if you have the gamma knife, or if you have the cyber knife. So I was fortunate to be able to work on multiple platforms. And as I said, a large number of indications are there. And just look at the extremely high dose of radiation. So this is at least 10 to 15 times the dose of radiation which will be delivered in a single radiotherapy session. And one classic example of a tumor in which the practice has shifted tremendously to radiosurgery is a case of acoustic neuroma. So this is a moderate-sized acoustic neuroma, which over 2 years, as you can see, is shrinking away after an outpatient treatment which lasted for 40 minutes. So I think this is my last slide. And what I would end is by saying that the functional neurosurgery field is so exciting, and there are so many changes which are happening, that this kind of work in which you are using functional neurosurgery for enhancing brain function is something which could happen in the future. And I think the crux of success in functional neurosurgery is a lot of teamwork between the neurologist, the neurosurgeon, the neuronurses, the technicians, the radiologist, the pathologist. So all of them contribute in great measure to the success in functional neurosurgery. Thank you.
Thank you, Professor. It's such an enlightening session, and it's always very pleasant to hear from you. So, if anyone has questions to Professor. So I think I should ask you one question. My confusion, sir. So do you think focused ultrasound will replace DBS in future?
Yeah, I think that is an excellent question. See, focused ultrasound is another lesioning modality. And I think the reason why it is becoming so popular is that it is non-invasive. So patients with these indications who do not want the conventional surgery, they are coming forward for lesioning using the focused ultrasound. Now, just like lesioning, focused ultrasound has its own limitations because you cannot do bilateral lesioning. That is why, so the first limitation is that you cannot do bilateral lesioning. The second limitation is that at present, at least in India, the cost of one ultrasound guided procedure is equal to the cost of doing DBS, in which you can put the leads bilaterally. So I think from the Indian perspective, and also maybe from the Asian perspective, focused ultrasound will become more and more popular for sure. I think newer indications will come forward for sure. But honestly, I do not think that it will be able to replace DBS completely.
Yes, sir. Thank you so much, sir. So for a country like ours, Nepal, I think Sindhu might have just mentioned, like we just started doing listening and then few DBS cases. So for us, like even patients coming to us can't afford for DBS.
Yes.
It's like a huge amount of money for them. And then we are actually kind of very tired of convincing the group of patients who come to us for the DBS, and we offer them listening. So, Professor, do you think like listening is also a good modality of treatment for the people in our area, like from
Yes.
Nepalese perspective or the Indian perspective?
Yes, absolutely. I think lesioning is an art which cannot be forgotten. And for many of our patients, in fact, it is the procedure of choice. So if I have a unilateral dystonia, if I have a hemidystonia, then I will not even offer that patient DBS. I will try to convince that patient that hemidystonia lesioning is the best option. The other thing which we can do is we can do lesions in different parts of the brain at one point in time. So in a single session, you could do thalamotomy for the side for which the patient has a predominant tremor, and for the patient with the side which has more of bradykinesia and rigidity, you could do a pallidotomy. So at the same time, you could do lesioning on different targets. For example, in Nepal, Professor Pant has done some excellent work in lesioning, and what they are combining is pallidotomy with a pallidothalamic tractotomy. These kind of innovative approaches, I think, are very, very important for our subcontinent, because we do not have the, the affordability in the population is not to the extent that everybody will be able to afford a DBS.
So, and then doing the other part of the brain, how much time do you like to wait for doing the lesioning in the other side of the brain?
No, so if you're doing lesioning in different parts of the brain, it can be done simultaneously. Yeah.
Okay. So, and then for the epilepsy, what do you think? Like we should, for us, like VNS is a bit cheaper than DVS. And then we haven't done anything of DVS for the epilepsy. So we have done VNS in only 2 patients. So what do you think? Like, is it, will it work? Like, will VNS replace the DVS for the epilepsy as well?
Honestly, VNS and DBS for epilepsy is less than 5% of the total indication. So I think the majority of patients will end up needing some kind of surgery, like extratemporal or temporal or disconnection. And out of 100, maybe 5 people will be candidates for either DBS or VNS. Now, the comparison between VNS and DBS, there is some limited literature to say that DBS is a shade better than VNS. But what happens is, in the pediatric population, the parents are not happy with their child having to have something done in the brain. And they are more happy if you put a VNS, which is in the neck, they are more happy with that.
Thank you, sir. So last time I did a short-term fellowship. It was kind of observership in functional neurosurgery in United States. And there I saw a professor doing, connecting 2 batteries either side. You know, so what do you think? For us, like we can't imagine doing that. But what do you think? Is it really necessary? We can.
So now, actually, if you want to put 2 electrodes in the brain, you don't need to put 2 pacemakers. That was in the older days when the Medtronic had come out with the pacemaker called Soletra. That used to be placed on both the sides. Now, these days, what is happening is for special cases of epilepsy and movement disorders, people are putting 2 electrodes on each side. So, for example, they are targeting the subthalamic nucleus and the pedunculopontine nucleus both at the same time. So, you have 4 electrodes in total. So, if you have 4 electrodes in total, then you will end up needing 2 pacemakers.
Okay. Okay. Thank you so much, sir. It's really an honor to hear from you.
Thank you so much.
So I would like to invite questions from other participants if they have.
Can I call upon Prof. Kim to give some comments, please?
Okay, can you hear me?
Yes.
Thank you. So I have one comment and one comment for two presentation presentation and one question for Dr. Aditya. So the first comment is for nurses in functional neurosurgery in our area, the nurses play a very important role. As Dr. Aditya said, we often perform awake surgery and we stand near the patient head here. So it's very hard for us to see the patient face emotion or notice small sign like weakness or seizure or we cannot see. So when a trusted nurse watches this thing for us, we can feel safe and focus on doing the surgery more accurately. So what I want to say is this really requires more communication with patients than any other area in neurosurgery. So we always need to stay close to patient and we talk with them because we often perform awake surgery and this is for so, patient's quality of life. So I hope you will remember this and keep speaking with your patient. This is one comment for nurses. And one question to Dr. Aditya. Maybe you don't remember me, but I listened your talk last year at Nobel Art of Listening.
Oh, yes.
It's very
Yes, we
glad to
met.
see you again. Yeah, very thank you. Yeah.
No, it's
So,
so nice to see you again.
oh yeah, thank you very much. Yeah. So, yeah, I have one question. It's very nice and impressive presentation. Thank you. So I have one question. So in India, after surgery, do neurologists adjust DBS programming or neurosurgeon do that? Who? Maybe in Japan, a neurosurgeon perform DBS adjust, and in Europe, neurologists do that. How about India?
So thank you, Professor Kim, for a very nice and interesting comment and also the question. I think in India, we have programs which are both ways. So I know of programs in India in which the neurosurgeons are doing the programming. And personally, what I like to do in my center is that I have a very capable movement disorder neurologist. So how we like to divide our roles is that I entirely take the care of the surgery part. And in the video, you saw that my movement disorder neurologist colleague was there assessing the patient in great detail. And following the operation, the medication adjustment and programming is both taken care of by the neurologist.
Wow,
That is what
great.
we do at our center. And I think it keeps the roles very nicely well defined. If I did not have a very good neurology colleague to help me, then obviously I would need to get into the programming part.
Thank you. So, as you know, in functional neurosurgery, accuracy is very important. For DBS, it is said that a shift of more than 2 millimeter can reduce the effect. So, do you have any special methods to keep high accuracy during surgery? Uh, I went to London University 2 weeks ago, and University College London, they take a post-operative MRI under general anesthesia. And if the lead is more than 1.5 millimeter often, they redo surgery on the same time. It's very impressive to me, but we don't do that. How about Indian?
Oh, so
For example, intraoperative MRI or anything you do?
no, we use the O arm. So whenever
Or
so we put leads on both the sides, then we do a O arm scan, and that is fused with the MRI.
huh?
So if it shows a deviation of more than 1.5 millimeters from the planned trajectory, then we will actually send the patient for an MRI and confirm that we are in the correct place. And only then we will insert the pacemaker. That is what we do.
Great. You have OR. Okay, nice. Thank you very much.
Thank you.
Is there any other question or comments from the audience? Prof. Gato, do you have any comments?
Not comments, Professor Gupta. Thank you very much for a great lecture.
It's a
And
pleasure to be
yes,
here with you. It's a pleasure to be
Yes.
here with you. I've met you at so many ACNS meetings. It's a pleasure to be with you.
Thank you. Thanks so much. So I think the contents is really good for the maybe not only the nurse but also the young doctors. So maybe as in the future is more and more the minimally invasive treatment is getting popular. I think maybe in your field, I think. How do you think maybe the future, your field, it's how change
I think
epileptic
we will
surgery?
see. I think we will see a lot of minimally invasive interruption of these circuits. Rather than having to remove a part of the brain, still we do a lot of epilepsy surgery and we are doing resections like temporal and extratemporal resections, even multi-lobar resections. I think all of these will reduce and finally we will have radio frequency guided multiple lesions. So you know that there is a multiple radio frequency lesion technique which is replacing hemispherotomy. You make 15 to 18 lesions around the basal ganglia, which disconnects the entire cortex and the white matter. So this is something which I think will happen more and more in the future. And I think there's also exciting work in terms of lesioning using the focused ultrasound. So I think definitely in functional neurosurgery also, we will be becoming more and more minimally invasive. Like even in DBS now, many centers are switching to a sleep DBS. Patient does not want to have the inconvenience and the pain, so they are switching to a sleep DBS.
Good. Thanks so much. Okay, all the best. Congratulations.
Thank you for the invitation.
If there's no further question or comments, I think we have come to the end of the webinar. Yeah, as all of us know, functional neurosurgery is advancing, and it is a teamwork with modern technologies, with good surgeons, neurosurgeons around, interventionists around, and it must be a good team of nurses, neuro nurses. So I think thank you very much for all the three speakers and our session chairs and commentator for the very wonderful session. Till we meet again next time. Thank you very much. Bye-bye.
Thank you. Thank you very much. Thank you.
Thank you.